This is Sg2 Perspectives, a conversation with Sg2 experts and industry thought leaders about the biggest trends in healthcare and what we expect that's going to mean for the future of healthcare delivery.
You're going to be losing margin. No one's going to be chomping at the bit to do that. But what we're trying to show, especially in the markets where there's still an opportunity to lead the market towards ambulatory surgery, is that this is the right move in a lot of cases.
Hello and welcome to Sg2 Perspectives. I'm your host, Tori Richie. Today, we are taking a deeper dive into the impact of change, focusing on one of our 6 impact factors, systems of care. This is how care is being delivered, and the care continuum needs to continue to evolve and transform over the coming decade to meet patient demands. I'm joined by 2 of our experts, Tony Guth and Rachael Zirkelbach. Tony, Rachael, great to have you today.
Thanks for having us.
Thank you.
So as we've kicked off this podcast series, we've grounded ourselves in an audio clip from the overarching Impact of Change podcast. I'm going to play back just a short clip for you all and would like to get your immediate reactions. When we think about the potential that partnerships have to transform care delivery, health systems do not need to go at things alone. Our recommendation is not that you need to scale an entire post-acute infrastructure using resources that exist within your healthcare system, but to think creatively, strategically about what community-based partners or even national partners exist to allow you to improve that care coordination so that you're opening access across the care continuum. Rachael, given your expertise that straddles both the post-acute space as well as the ambulatory space, how are you starting to see health systems evolve their care delivery models to operate more efficiently and achieve those economies of scale?
From a post-acute perspective, that quote says it all. Our members, they are doing exactly that. Even from organizations who are just starting out and looking at their post-acute relationships within their community and what type of post-acute relationships they have, to the organizations who have the more streamlined, well-oiled machines. They have realized that they can't do it all and they need those partnerships to achieve those economies of scale. From that post-acute perspective, they've relied on those partnerships, bringing them to the table to find which patients go to, whether it's a SNF or an inpatient rehab, or is it the home, and then getting those patients decanted from the inpatient setting in an appropriate manner. Tony and I talk to a lot of organizations who are looking at outpatient surgery, ambulatory surgery centers specifically. That's a lot of places where hospitals specifically are looking for partnerships because they can run hospitals pretty well, but they're looking for that partnership on the ambulatory surgery side too. I don't know, Tony, would you add anything there?
You nailed the importance of partnerships in post-acute care space, and you're absolutely right about the surgeries component as well. We forecast the surgery service line group, and a lot of that stuff is outpatient. So if you're thinking appendectomies, hernias, choles, some bariatric surgery, a lot of it's outpatient, and some of it's moving to ambulatory surgery centers, a space that legacy health systems that are a little more hospital-centric, they're not very efficient at running these facilities. It's hard to run a tight ship because it's not like running a hospital, and it's hard to make a profit if you run an ASC like a hospital. Partnerships are really important here. A lot of our members are trying to find the right management company to partner with to be able to basically hit the easy button and make sure that you have an ASC that's running like a well-oiled machine. We just saw a couple weeks ago the idea of maybe Ascension buying AmSurg. Health systems realize that they need partners to be able to do things that are not traditionally in the scope of work of a hospital-based health system. It's a really good way of getting stuff done because we've been talking about this forever, Tori, in our forecast. There's going to be a lot of growth, and there's going to be a lot of growth in areas where you don't play. It's okay to not own that care delivery model and maybe just befriend those who can do it well and make sure that it's contributing to your mission, vision, and values and taking care of your population.
It seems to me that every organization is being given the directive to grow. What that means might vary across organizations. Maybe that means grow margin. Maybe that means grow volume. Maybe that means grow market share. But there's this underlying strategy of doing more, basically. And I'm curious, Tony, maybe I'll start with you. Beyond partnerships, what should health systems be thinking about to achieve those growth directives?
Growth is a really important strategic imperative and very common because margins are pretty slim or negative. You want to find volume. Just like any other business, if we're not making a ton of profit on every single widget or encounter in the health system, then we need to grow volume. It's not just growth, it's smart growth. we work with our members to try and figure out what's growing, but what's growing and belongs in a hospital, and what's growing and belongs in an ambulatory setting, and making sure that the patient shows up at the right place at the right time. We're working with our large community hospitals and AMCs to isolate the quaternary and tertiary cases, trying to find them and making sure that we decant some of the low acuity stuff out of the hospitals and backfill it with those quaternary tertiary cases. That's the imperative to grow. It's growing what should be growing at the right setting. Because if you're growing something that is low acuity, low margin, negative margin, and for lack of a better term for it, taking up space in a hospital when they could be taken care of at their home in their community setting, that's a mistake. It's about smart growth, not just growth.
And Rachael, I'm curious, to enable that smart growth, we need to improve throughput, which means shoring up inpatient operations. One key strategy for achieving that is then making sure that our post-acute infrastructure is right-sized to meet that demand. What is your recommendation to organizations as they start to figure out what those PAC needs are, where they should begin in terms of piloting programs?
Looking at discharge disposition, where their patients going right now, and assessing the need, but also where do they want to grow into. There's a lot of consumer interest in recovering in home. That smart growth, a lot of procedures have shifted to the outpatient space already. That means that patients don't necessarily need a SNF stay anymore, but they may still need some level of post-acute care or post-surgical recovery. And that may happen in the home. Shoring up that not only those partnerships for that higher acuity level of care, whether that's the SNF or the inpatient rehab facility or the long-term care facility, but also looking at your home partnerships. If you have home health or home PT/OT or different things like that, our Home Visits Other, which is the CNAs and different professionals there that can help round out that home care. Looking at the home is the next frontier in helping move those patients along in the journey.
And there's so much innovation that's happening in the home space. Could you talk to some of the advances that we're seeing in digital technologies that are allowing that home side of care to be supercharged as it relates to growth over the course of the decade?
We're seeing a lot of advancements there. We've got remote patient monitoring. We've got some organizations that are using ambient technology. I keep coming back to partnership in this space because it can be a partnership with technology. Do you need somebody who brings in the tech like Best Buy, who will come in and set a patient up for hospital at home services or other type of home services, who can enable that care at home so that the clinicians can take care of caring for the patients? There is that level of partnership there.
That's spot on. And what you're describing too, it really is an evolution of how we are providing care to patients. It seems organizations are getting more and more creative with how they meet demand and recognize the fact that the pathways that they've perhaps used in the past, it doesn't make sense for them to continue to retrofit future delivery needs in the ways that they have historically operated. Tony, this is a concept that we've talked about at length on the ambulatory side of the house. And we don't need to go too far down the ambulatory first rabbit hole, and certainly encourage listeners to check out our recent Ambulatory First podcast episode. Tony, could you give listeners a taste of what some of those concepts are on the ambulatory side that we think organizations should investigate as it relates to transforming their care continuum?
We wrote that piece on what it means to be an ambulatory first organization. And the whole point of it was to get our members to wrap their heads around the fact that their business models are just set up in a way to put the hospital first. It seems kind of common sense, but the reason why we don't succeed or we haven't reached this vision of what the ambulatory setting can look like, we've been talking about it forever. It's patient-centric. It's mostly in the home or virtual or in these clinic settings. We're taking care of patients in a proactive way so that they don't have their diseases progress to the point where they need to show up in the hospital or the ED. We are struggling very hard in achieving that vision. And the reason why is because the business model is messed up. It doesn't prioritize ambulatory first. We need to do a few things differently. First, we need to make sure that we have an ambulatory side of the business. meaning that this part of our business needs to be able to stand on its own. If our hospitals disappear tomorrow and we're only left with our ambulatory settings, we should be able to turn a profit and continue doing business. Our competitors do this, these very nimble disruptors who only play in the ambulatory space. They don't have hospitals. They're making money off of this. They're doing well and they're taking care of the patients. So we need to think more like them and be able to do that. Capital planning is another thing. We need to give a boost, to give a leg up to ambulatory projects when they're brought to the table every year, when we're thinking about how we need to spend our capital, whether we have a lot or a little. Make sure that we're having these smaller, more frequent ambulatory projects that allow us to be more flexible with our capital and not have it tied up and maybe building huge towers or extensions to our hospital when arguably we don't need them. The workforce component is extremely important. We need to have a flexible way in which we deploy the workforce. We can't just have FTEs tied down to a single brick and mortar locations. They need to be cross-trained. They need to be supported by AI and tech to the fullest extent. The possibilities are going to grow exponentially regarding how we can extend the reach of every single provider over the next 3, 5, 10 years. I don't think we know what we don't know yet. The workforce is the third one. And the fourth one is the org chart. We need to make sure that we have an ambulatory leader who's elevated to be a peer to the hospital leadership. We need someone in the C-suite. We need someone who's representing the ambulatory side of business and has the right incentives to make sure that the ambulatory setting succeeds, is profitable, is taking care of these patients in more appropriate settings, and just a functioning part of our business model. So that's what we mean by being more ambulatory first, making these conscious changes to prioritize ambulatory, to make sure it succeeds, and set us up for a more stable future that is one where more and more care is outside of the four walls of the hospital.
What is your reaction to somebody who is reticent to shift away from traditional care models? Maybe surgeries haven't shifted from the inpatient care setting yet within their market, or they haven't seen the need or demand for care to shift to home. What recommendations do you have to them to get over that initial barrier of starting to innovate and evolve on care pathways?
My first reaction is that I get it. There's a reason why most of our members haven't made this shift to become a more ambulatory first organization or specifically to move surgery to lower acuity sites. It's scary because you need to have some kind of risk aversion level at most health system leadership levels right now. You need to be able to take on some kind of risk or be willing to take on some kind of risk. If you're talking surgery specifically, you have to be willing to cannibalize from yourselves a little bit. If you want to move faster than the market, you're leaving some money on the table, and you got to have the willingness to lose some of those hospital outpatient department rates and get paid less in a lower acuity site. So you're going to be losing margin. No one's going to be chomping at the bit to do that. But what we're trying to show, especially in the markets where there's still an opportunity to lead the market towards ambulatory surgery, is that this is the right move in a lot of cases. Let go of those HOPD rates and try and lead the market so that you're better positioned to stay extremely relevant in the future of surgery in your service area. Another one is just bandwidth. We've seen this trend coming for a while now. This is not entirely new. The urgency might be increasing, but we're so busy in our day-to-day work, and that really emphasizes why strategy is extremely important. Strategy is paramount. It's important to do the blocking and tackling, probably transcend strategy, but you need strategy to make sure that you're actually heading in the right direction. And if you don't have that, you're going to be moving down this groove that you've built for yourself when your competitors are finding an opportunity to take some of your business and you're just not aware of it. You're going to move too slow. You're going to be a distant follower at best, and you could be finding yourself in trouble. So it's a combination of risk aversion and simple bandwidth.
Rachael, what would you add?
From a post-acute perspective, I agree, Tony, on the bandwidth. There's a lot of shortage in nurses and other medical professionals that go into the home. And then when we talk about the workforce ratios in skilled nursing, that's still a rule we're going to see as those skilled nursing facilities adjust to handle those workforce ratios. We're probably going to see more patients shift to home care. We're already seeing a constrained workforce be constrained even more. So do you have the workforce, and do you have the workforce that then wants to go in the home? And if you're going into higher acuity care in the home, that's another workforce altogether, because you need a specific type of nurse who has the skill set to handle that high acuity type of care. But Tony, I definitely agree with you on this strategy perspective, because consumers want to receive care in the home, and there's only so many outpatient sites of care that you have a limited amount of resources. You can't build as many outpatient sites of care as there is needed. So the home seems to be another viable option. Tori, if we're forward thinking, I think in post-acute, we see WellSpan using Hippocratic AI. They launched a Spanish-speaking AI agent who has higher call connection rates, longer engagement, and more screening requests from Spanish-speaking patients than their English-speaking counterparts. When we're talking about technology and we think about how AI could be used into the future, we know that home-based care depends on patients and families taking more of an active role in tracking symptoms, managing medications, and preparing for virtual visits. Similar to how WellSpan is using this Spanish-speaking AI agent, could this AI agent be leveraged in the post-acute realm to confirm readiness for a virtual or in-person home visit, offer medication or equipment reminders, triage some symptoms, or support chronic condition monitoring? This could especially be impactful in those rural and multilingual or underserved populations because it can dramatically extend the reach of those clinical teams and possibly reduce those emergency escalations in the emergency department.
I love that example because so often organizations that I talk with are having a hard time justifying investing in the home space because reimbursement can be challenging. It's not thought of necessarily as a revenue generating program. By deploying programs like what you just described, even if the program itself isn't generating revenue, it's making your system as a whole operate more efficiently. It's helping to reduce the indirect cost of folks not being able to manage their medications, of folks experiencing a progression or escalation of their chronic disease or what have you. So the cost savings that exist by making that proactive investment is the game changer.
You're exactly right. It's about that strategy, the proactiveness on the front end.
It's so frustrating because I recognize that the finance team or the board wants to see the financial implication or the direct ROI that's tied to programmatic investments. Getting organizations to think more creatively and more proactively about how they should approach care redesign is going to be key if folks want to be successful long term.
You're spot on there. Looking at how many patients are using your emergency department, and if you are having more frequent touches in the home, maybe they're not using your emergency department as often. How much of that downstream care can you potentially avoid because you made that investment up front?
And to Tony's point, if you're able to prevent that utilization, you can then redistribute that capacity so that you are tending to truly the sickest, the most complex patients in those ED inpatient settings. And you're not being bogged down by folks where if they had been better managed, they wouldn't have had to come into the facility altogether. Rachael, Tony, I'm curious, you spend thousands of hours each year researching the ambulatory space, the post-acute space, the surgery service line. In preparation for this year's forecast refresh, what was one piece of research that changed the way you approached the forecast?
There were two things this year that were top of mind for us that were interesting. One is we were underselling the effects of the GLP-1 drugs the previous couple of years. What we were seeing in the data and all these articles that come out showing the different indications that this drug is good for, we wanted to expand the impact of that drug on our specific service line, on the surgery service line group. We had, for quite a few things, some downward pressure for conditions that have obesity as a risk factor. I think we pushed down hernia a bit. We pushed down the appendectomy a little bit. We don't technically forecast bariatric surgery. That's the medicine service line, but that's going to be a little bit more bullish than it has been the past couple of years. We've tried to make a connection between obesity and our specific disease states and procedures that we forecast, and we revisited them this year to the tune of maybe a point or two or three going in the downward direction. So that's one thing. And the other thing we're paying attention to is the medical management approach for appendectomy. Now, we've been forecasting appendectomy growth up until a handful of years ago, but we've been forecasting a decline for appendectomies, inpatient and outpatient. We expect fewer appendectomies 10 years from now than there are today. And that's because there is this approach where medical management, antibiotics are as good as surgery in a lot of cases. Not all of them, but a lot of them. We haven't seen it in the data yet. This is something that we're forecasting some expectations for. Anecdotally, I have quite a few members who call. I had 2 calls in the past couple of weeks, actually, from members who explicitly asked why they're maybe seeing soft volumes for general surgery. the medical management approach for appendectomy came up, and also the effect of GLP-1s. So I think those are two things that we thought about this year that maybe we didn't emphasize the previous few years. So those two things are top of mind for me.
Tony, Rachel, always so fun to have you on the podcast. Appreciate you joining me today. Thank you so much for sharing your insights.
Thanks for listening. If you like this episode, please subscribe, rate, and review us, and or follow us on Twitter and LinkedIn at Sg2 Healthcare. And if you want to talk more about innovative healthcare strategies, you can always email me at sg2perspectives@sg2.com. Finally, Sg2 is a Vizient company, and there are a bunch of Vizient podcasts that you might like. You could find them at Vizient /podcasts. Have a great day.